Good morning, everyone. On behalf of my esteemed friends, colleagues, and co-directors, Drs. Conrad Smith and Hemel Gada, we welcome you to Pittsburgh. You're joining an audience of nearly 800 physicians, nurses, advanced practice providers, trainees, and other healthcare providers who take care of patients with heart valve disease. We're absolutely excited about today's program, and we are confident you will feel the same by the end of today. In addition to the usual talks and didactics and interactive case discussions, today we are pleased to present to you two live recorded cases, one from Pittsburgh and one from Harrisburg that'll be moderated later this morning by our panel. A special thanks to the Society of Thoracic Surgeons and the Congenital Heart Academy for supporting and endorsing our program. We are truly grateful for their partnership. I would also like to thank our industry partners for their assistance. Today would not be possible without their generous support. I'm truly grateful to our physicians expert from the UPMC Heart and Vascular Institute who are here today to share their knowledge, experience, and wisdom. The UPMC Heart and Vascular Institute is one of the largest integrated cardiovascular service lines in North America. And I'm absolutely blessed to work shoulder to shoulder with these national and international experts. Most importantly, I would like to thank our patients who allow us the privilege of being part of their journey with heart valve disease. With that, I will introduce my partner and esteemed colleague, Dr. Conrad Smith, who will be moderating our first session. Dr. Smith is the director of our cardiac cath labs, associate chief of cardiology, and the medical director of the heart valve program. He's a nationally renowned interventional cardiologist and a very thoughtful and highly skilled interventionalist that I know and is passionate about heart valve disease. We are fortunate to have him with us today. Thank you once again, and welcome. Thanks.
Thank you, Yves. And welcome. I'd like to share my welcome as well. I think we have an excellent group of physicians and researchers to speak with us today on a whole host of valvular heart disease. I have the pleasure of chairing the first session on aortic valve disease. And the order of events is we'll have the series of talks, and at the end we'll have 15 minutes or so to have a moderated session and some questions. And with no further ado, I think we'll get started. The first of our presenters, I'm happy to introduce Dr. Dustin Kliner, who is an outstanding interventional cardiologist. He has really built a great presence in the structural heart disease arena, and he's here to talk to us about TAVR and low-risk patients, and he's going to tell us, are we there yet? Dr. Kliner.
Thank you, Conrad. Thank you, Yves. Thank you, Hemel. We'll get started. It's a little bit of a misleading topic. I think we are there. We're not maybe there for everybody, which is what I want to convey to you. I do some speaking for Abbott. Objectives today, we'll talk about the available data in TAVR low-risk patients. I'll tell you about the limitations of TAVR in younger patients, and I'll highlight the role for shared decision-making between surgeons and interventional cardiologists, which is the crux of most of what we're going to talk about today. We'll start with a case scenario, as we always should, bring it back to the bedside and talk about the patient. 64-year-old non-medical family friend who has severe symptomatic aortic stenosis. He read the New York Times article and saw Mick Jagger on stage a few days later and said, hey, he looks great. If I need to have my aortic valve done, maybe I can do it that way. He's otherwise healthy. What would you recommend to him? So low risk, what do we mean by low risk? This is the Society of Thoracic Surgeons predicted risk of mortality of less than 3%, with no other life-limiting condition not factored into the STS calculator, and there's no evidence of objective frailty that would add incremental risk to these patients. We have two randomized controlled trials that I'll touch on, and we have some incremental follow-up of those that have occurred over the last couple of years. The first is the Medtronic low-risk trial, so 1,400 patients, mean age of 74, so a little bit older than the patient that I describe in the scenario, looking at a composite endpoint of death or disabling stroke at 24 months, so 2 years of follow-up in the initial trial and the initial publication. The primary endpoint occurred in 5.3% of TAVR patients and 6.7% of surgical patients. At 30 days, stroke rates were lower, bleeding rates were lower, AKI and AFib rates were lower with AFib, which occurs with almost all TAVR versus SAVR trials. moderate to severe AI rates and pacemaker rates were higher with TAVR patients than they were with surgical patients. And at 12 months, TAVR patients had a lower mean gradient and larger effective orifice area. And these are, again, consistent amongst all TAVR trials from multiple different risk strata of patients over time. We have updated 3-year follow-up information in this, and you can see now out to 36 months, we still do have a nice separation between the curves, looking at all-cause mortality or disabling stroke amongst the TAVR and surgical groups. So self-expanding TAVR with the Evolute platform still performing fairly well relative to surgery 3 years out. Partner 3 trial, this is 1,000 patients looking at the Edwards Sapien platform in low-risk patients, mean age 73, so again, older than the patient that we've described in our case scenario, average STS of 1.9. This looked at death, stroke, and rehospitalization at 1 year, so they've added a third factor into their composite endpoint. This occurred in 8.5% of TAVR patients and 15% of SAVR patients. The 30-day stroke rates were lower with TAVR, as were death or new stroke, again, atrial fibrillation, shorter hospital stay. And in this trial, there were no differences with moderate to severe PVL or pacemaker inserted. The self-expanding valves, the balloon expandable valves historically have had slightly smaller rates of pacemaker insertion and PVL amongst trials, again, across risk stratification schema. If we look at the box and whisker here, you can see the separation of all of these. At the top, there's an age less than 74, which I want to point out, and that is not something that stays completely on the TAVR better side of the curve. And you can see at the very bottom we have overall KCCQ scores, atrial fibrillation numbers, multiple different strata that are there, and most of these, again, favoring TAVR fairly strongly. This is the 2-year follow-up for this particular trial. So I want to point your attention to the top right-hand image, looking at the 12-month separation of curves as compared to the 24-month separation of curves. You can see that things are starting to catch up a bit when it comes to the difference between surgery and TAVR, and this is what has been seen in some of the other risk strata, as I'll outline later. What about bicuspid valves? So if we talk about patients less than the age of 65, rather than degenerative, bicuspid is one of the main causes of severe aortic stenosis in this group. So John Forrest and colleagues looked at 150 patients using self-expanding TAVR, 136 with a Sievers type 1 bicuspid morphology, and showed successful implantation with all-cause mortality and disabling stroke low, device success rate of 95%, and they're planning 10-year follow-up. So we will have some data with bicuspid valves. The problem with bicuspid valves is it's not a binary variable. There are multiple different morphologies and calcification distribution in bicuspid valves that make some of these more challenging. So what is a lifetime plan? A concept that our congenital surgeons have been talking about for a long time, and we're finally catching up. If we have a 70-year-old who's still working, should we let them have a transcatheter valve now and do an open when they're 80 if they require a redo and we cannot do another transcatheter valve inside? If they have a large annulus, should we just layer TAVRs inside? If they're young, should we do a tissue valve now and a TAVR later? And the question I often pose to patients is, if we think we've got one shot at this and you're going to have an open surgery, would you want to do that at age 70 or age 80? So how long is this thing going to last? So the valves that were FDA approved have been subtly adjusted since 2019. We do not have long-term data on the particular strata or the particular variation of the valve that we're using today, just based on the FDA approval. And when these were done in 2009 and 2010, we were doing them in 90-year-old patients. So we don't have 10-year follow-up. Those patients simply aren't here to tell us how their valves are doing at this point. There's been a lot of discussion about the notion in UK TAVI registries, which are two of the largest follow-ups that we have, talking about good long-term function. If we look a little deeper into those, we see that the UK TAVI registry first, 241 patients that had a baseline in a greater than 5-year transthoracic echo, mix of self-expanding and balloon expandable. And if you look at the bottom, 21 cases that are still alive of moderate structural valve deterioration at 8.7%. However, if you look at the curves all the way to the right at 8 years, there are only 44 patients that are still around to tell us whether they have moderate or worse structural valve deterioration. So we're dealing with small numbers, and now that we have 21 or 22 with structural valve deterioration out of 44, that doesn't sound as good as 21 out or 22 out of 240. The Notion registry is very similar with TAVR and SAVR, equal parts. The structural valve deterioration was higher for SAVR than TAVR, which is 24% as opposed to 5%. Bioprosthetic valve failure that required reintervention was similar amongst groups. And this is the graph there. Again, if you look at the number at risk, we have quite low numbers at risk when we get out to that 6-year endpoint. These are the rest of the long-term data. I wanted cricket noises, but I ended up with cricket pictures. There's really not a lot here. We're in a data-free zone as far as the long-term outcome. So why don't we do a TAVR and then just do a second TAVR inside? Gilbert Tang and colleagues looked at 551 SAPIEN patients. The SAPIEN valve is the annular valve. Theoretically, one would think this would be easier to do a TAVR inside a TAVR, and came up with a classification schema relative to the sinotubular junction, the height of the sinotubular junction, and the coronary access that would be possible if we put 2 layers of SAPIEN inside each other. The most important part, if you look at the right side of the screen, is if your initial transcatheter heart valve comes above the sinotubular junction and makes contact with the sinotubular junction, your ability to put a second valve inside and still have access to the left main coronary is going to be significantly limited, and that occurs up to 30% of the time. So this is not a one-off finding. This is quite a frequent finding. Let's talk about the newer data. So the partner data that has had multiple risk strata done. This is the intermediate risk data, looking at patients that received the S3 and are planning on 10-year follow-up. This is their 5-year data that was published. If you look at 0 to 24 months, which was the initial publication, we have a significant, really superimposition of the curves between transcatheter valve and surgery. And in the iliofemoral group, this was statistically significantly in the favor of TAVR. But look what happens between years 2 and 5. We have a complete flip-flop in the curves that we see, with TAVR not performing as well as surgery from years 2 to 5. So this is a very important indicator that in patients who are even lower risk for the initial intervention, what are we going to see with our low-risk trial as we have 10-year follow-up? Back to your family friend. So when you're counseling these folks, you say we've got 2-year follow-up for the Edwards valve and we have 3-year follow-up for the Medtronic valve. Unfortunately, for most 65-year-olds, they're not worried about 2 and 3-year follow-up. They're worried about 10 and 12-year follow-up, which we just simply don't have at this point. Limitations of TAVR, valve durability, longevity is unknown. As I said, optimal strategy for treating a failed TAVR is unknown. A permanent pacemaker is probably not a big deal if you're 85, but if you're 60 and have to deal with multiple lead recalls and potential bacteremia issues in your life, that's a major issue. And we're also not able to treat concomitant conditions that would come up: left main, ascending aortic disease, other valve disease. So who do I think should still have a SAVR in 2023? Low-risk patients with coronary disease, especially left main or LAD. I think we would all agree as interventionalists that a LEMA will outperform a drug-eluting stent for severe proximal left anterior descending disease or left main disease. Patients less than 65 and maybe 70 should probably get a mechanical valve, and that's only surgically available at this point. Bicuspid aortic valve disease and concomitant aortopathy, and then patients with a greater than 20-year life expectancy. TAVR for all, what we need long-term durability data. We need 10-year follow-up data from our low-risk trials. We need a better strategy and placement of our first valve to optimize the potential to have a second valve. And we're still waiting for the randomized data for TAV and TAV, which we don't have yet. Where are we now? This is my last slide that I wanted to point out. This is a paper that came out this week looking at indication creep in TAVR versus SAVR from Mike Reardon and Sachin Goel. So there was this Vizient database from 2015 to 2021, 17,000 patients that were less than 65 treated with an aortic valve replacement. And look at the number that's treated with a transcatheter valve. So our guidelines say greater than 65 should be considered for TAVR. Less than 65, 47% are currently being treated with TAVR. So we've taken some liberties here. I'll take any questions you have. That's my contact information. And this is a famous Simpsons episode where, the kids say, "Are we there yet? Are we there yet? Are we there yet?" And Homer just continues to say no the whole time. So I agree with him on this one. Thank you.